My name is Diana Vancia, and today, March 19th, I will be presenting my Case 1 presentation on achalasia. Typical patient presentation. A 52-year-old man presents to his physician with dysphagia, regurgitation, and unintended weight loss. He notes that he recently started working as an over-the-road truck driver and mentioned that when he eats in his truck while driving, quote, "the food feels like it's stuck in my chest," end quote. He was treated for a peptic ulcer caused by the presence of Helicobacter pylori 2 years ago. Achalasia is a degenerative condition. However, the etiology, or the underlying cause, is idiopathic or unknown. There are a few working theories, some of which are more prevalent than others. One of the theories includes gastroesophageal junction obstruction, which is the elevation of the integrated relaxation pressure of the lower esophageal sphincter, or the LES. Another working theory is neuronal degeneration. This specifically refers to neuronal degeneration of the myenteric plexus, leading to loss of gastrointestinal tract motility. Viral infection is the most prevalent of the theories, and this specifically refers to the nerve cells of, again, the esophageal myenteric plexus by a neurotrophic virus. A neurotrophic virus is a virus that is capable of infecting nerve cells. Genetic inheritance is another one of the theories. When this is the case, it is referred to as familial esophageal achalasia. Autoimmune diseases are also one of the theories for the etiology of achalasia, which more specifically includes multiple sclerosis, MS, lupus, and type 1 diabetes. The background for achalasia is it is known as an ancient disease, and there are a few important dates for achalasia, including 1671, 1881, and 1929. Achalasia was first discovered in 1671 by Sir Thomas Willis, who is pictured in the upper right-hand corner. In 1881, von Milkowitz described it as cardiospasm, in which the symptoms were functional issues and not mechanical issues. In 1929, Hurt and Rake realized that the disease was caused by a failure of the lower esophageal sphincter, the LES, to relax. They then coined the term achalasia, meaning failure to relax. In the United States, the new case rate is 1.6 cases per 100,000 individuals. The case rate is 10 cases per 100,000 individuals. Again, to clarify, new cases are 1.6 cases per 100,000 individuals. Risk factors for achalasia. It has been seen that both males and females are equally affected. It is most prevalent among people ages 25 to 60 years, and it is commonly found in people who have Allgrove syndrome. Allgrove syndrome is also known as AAA syndrome. It is a multi-system disorder which involves a triad. That triad includes esophageal achalasia, allocrima, which is the inability to produce tears, and Addisonianism, which is an adrenal insufficiency due to adrenocorticotropin hormone insensitivity. The pathophysiology of achalasia can be explained through a multi-step process, beginning with degeneration of ganglion cells of the myenteric plexus in the esophageal wall, then the failure of smooth muscles of the esophagus, smooth muscle atrophy, and failure of relaxation of the LES, or the lower esophageal sphincter. In the key on the bottom left, you can see that the words highlighted are symptoms connected with each step of the pathophysiology. And again, going back to the theories of etiology, many investigators have proposed that inflammatory attack on esophageal neurons in achalasia is triggered by an antibody response to viral infections. including herpes zosters and measles viruses. Data has, however, been inconclusive. Pathophysiology continued. So here we can see a normal esophagus with a lower esophageal sphincter in comparison to an esophagus with a lower esophageal sphincter when you have esophageal achalasia. So we can see in the normal, you have an esophagus and a lower esophageal sphincter. It goes down like a straight line, therefore food can easily enter. However, when you have dilation of the esophagus in esophageal achalasia, the lower esophageal sphincter does not relax. Usually when you would have dilation of the esophagus, the lower esophageal sphincter would relax. However, when you have achalasia, it constricts, not allowing the food to come in and leading to that sensation of food being stuck in the stomach, that heartburn sensation, and the overall feeling of discomfort. Achalasia increased lower esophageal sphincter muscle tone and loss of peristaltic function, which is going to prevent food from entering the stomach, which is going to cause esophageal distension. Pathophysiology further continued. Here we can see another picture of what is called bird beak appearance of the esophagus when you are experiencing esophageal achalasia. You have the narrowing of the lower esophageal sphincter, and you can see that in the photo on the left, as well as on the right in the drawn image. The clinical manifestations of this will include dysphagia, which is difficulty swallowing, adiponophagia, which is painful swallowing, and regurgitation, which is the backward flowing of undigested food up the esophagus. Symptoms of achalasia. In the case presentation, I said a 52-year-old man presents to his physician with dysphagia, regurgitation, and unintended weight loss. These are all key symptoms that point that it may be a condition or a patient that is experiencing achalasia. Dysphagia and unintended weight loss are definitely two of the biggest symptoms. Other symptoms include, again, regurgitation, chest pain, heartburn. The unintended weight loss is going to be due to decreased food intake as a result of discomfort. So patients with achalasia will have a sensation that swallowed material, including both solids and liquids, gets stuck in the chest. And that is also where we get the chest pain and the heartburn. A lot of time, achalasia is just dismissed for severe acid reflux. And so that is why it is important to diagnose achalasia, because it can be extremely discomfortable. It can be extremely uncomfortable for patients. And again, we see patients that have decreased food intake because of these discomforts. Again, in the case presentation, I also noted that he notes that he recently started working as over-the-road truck driver and mentioned that when he eats in his truck while driving, quote, "the food feels like it's stuck in my chest," end quote. This is a common patient complaint, and again, it comes from that sensation that swallowed material, again, including both solids and liquids, is getting stuck in the chest. So that is a common patient complaint that you will hear with patients who are experiencing esophageal achalasia. Therefore, hearing the symptoms, we know it is very important to diagnose achalasia properly, and there are a few tests that have been developed, one of which the most popular is the barium swallow. This is going to allow medical professionals to identify that bird beak appearance using esophageal dilation, and more detail about the barium swallow will be provided on the next slide, slide 11. Esophageal manometry shows the incomplete LES relaxation in response to swallowing, high resting LES pressure, and absent esophageal peristalsis. Esophageal pH monitoring is used to rule out gastroesophageal reflux disease and determine if abnormal reflux is being caused by treatment. So actually, when patients are being treated with achalasia, severe acid reflux can occur, and therefore esophageal pH monitoring will be able to see if that is happening and then make changes to the treatment in order to make the treatment process a more comfortable one for patients. An esophagoduodenoscopy is used to rule out esophageal squamous cell carcinoma due to high correlations between esophageal achalasia and esophageal cancer. Patients with achalasia actually are at 50 times a higher risk of presenting with esophageal squamous cell carcinoma than the general population. The esophageal squamous cell carcinoma usually manifests 20 to 25 years after achalasia symptom onset. Then we also have concomitant and endoscopic ultrasonography, which is done if a tumor is suspected. So again, more information on the barium swallow. This is going to allow medical professionals to identify the bird beak appearance of the esophagus, and you're going to have dilation of the esophagus and stasis of the barium. And here again, I put a picture of a bird so you could compare the esophagus to that, again, bird beak appearance. The characteristic findings of achalasia on a barium swallow include a persistently narrowed region at the end of the esophagus, which is going to be the lower esophageal sphincter, with a dilated esophagus above the narrowed region. So this is consistent with the pictures of achalasia that we saw in the previous pathophysiology slides. So you're going to have that dilated esophagus and that constricted lower esophageal sphincter. For treatments, there are two categories, non-surgical and surgical treatments. Non-surgical treatments include calcium channel blockers and nitrates, as well as botulinum toxin or Botox. And surgical treatments include the POEM, the peroral endoscopic myotomy, and the EndoFlip, the endoluminal functional lumen imaging probe system. And I will go into more detail in upcoming slides. So again, non-surgical treatments. You're going to have calcium channel blockers and nitrates. This is going to be used to decrease lower esophageal sphincter pressure, and it is used in older patients who cannot undergo pneumatic dilation or surgery due to the post-operative complications and just the stress that surgery puts on the body is not preferred for patients who are of older age if the problem can be temporarily resolved using a non-surgical treatment. That is preferred for those patients. And this is going to inhibit the cellular reuptake of calcium and therefore does not allow for contraction of that lower esophageal sphincter. So it's going to promote the relaxation. Botulinum toxin or Botox is going to be an endoscopic intrasphincteric injection of Botox. This is going to allow acetylcholine, ACH, to release at the level of the lower esophageal sphincter. So it's going to block that, to clarify. Older patients who cannot undergo, again, pneumatic dilation or surgery. So non-surgical treatments are usually preferred for people who are at high risk of post-operative conditions. Surgical treatments include the POEM, the peroral endoscopic myotomy. So this is going to go through the mouth and treat the disorder by cutting the muscle. Steps to this include the endoscope entered into the esophagus, 2, the incision made in the mucosa of esophagus and through it the inner circular layer muscle is removed from the last part of the esophagus, the lower esophageal sphincter, and the upper part of the stomach. And the last step is that endoscopic clips will be used to close the initial incision. The EndoFlip, the endoluminal functional lumen imaging probe system, measures esophagogastric junction distensibility to detect contractility of esophageal body. And both of these are going to be explained in further slides. The EndoFlip will be explained on slide 16. The EndoFlip The endoflip is used to measure diameter pressure to determine dimensions and functions of hollow organs and sphincter regions in the GI tract. So for esophageal achalasia, this will measure the diameter pressure of the lower esophageal sphincter, or the LES. It's going to measure the diameter in 16 points and show the measurement of diameter and pressure both graphically and numerically. And this allows you to measure volume across the selective area as well. The endoscopic functional luminal imaging probe, or endoflip, is a new technique that's able to measure esophagogastric junction distensibility in achalasia patients. These are my references. Thank you.